Hello, and welcome to a Facebook Twitter Live event. I'm Francis Collins, Director of the National Institutes of Health. I just took off my mask because I'm socially distant from anybody else anywhere near me. And so did my guest, Dr. Tony Fauci, who is the probably best known infectious disease expert in the world, and certainly familiar to most of you from the very prominent role he has been playing as we've tried to address this global pandemic called COVID-19. As a member of the White House Task Force, as somebody who has long experience in the area of infectious disease and particularly vaccines and therapeutics against infectious organisms, as well as his role as director at NIH of the National Institute of Allergy and Infectious Diseases, there's nobody better to tell us about what is happening right now with this effort to try to deal with this dreadful global pandemic, which has already taken about 230,000 American lives and which is unfortunately on an upswing right now with more than 70,000 cases each day now being recorded, particularly across the middle of the country. So if there was a moment of urgency all along, it feels particularly that way right now. And we're here to talk to you about what has been happening with the effort to develop vaccines, which I know everybody is intensely interested in. So Tony, I'm going to ask some questions. People can actually send in their questions live, and we'll try to answer as many of those as we can in the half hour that we've got. But let me start out with what recently happened with one of the vaccines, the one that is being developed by the company called Moderna, but which started as a project in the Vaccine Research Center right here on the NIH campus, a few hundred yards from where we are at the moment. So Moderna announced that they had completed their enrollment of 30,000 participants in their vaccine trial. And it was particularly gratifying that they were able to enroll participants who were diverse in their backgrounds. 37% of their participants were people of color, more than 10% African Americans, more than 20% Latinx. Why does this matter? Why is diversity important for these trials?
Well, Francis, that's a great question, and it is critically important for the following reason. We hope and I believe we will get to the goal of showing that this vaccine is both safe and effective. We really do need to get everyone who could possibly benefit, particularly the most vulnerable in our population, ultimately to receive the vaccine when it is available. The only way we can, with confidence, look at our colleagues of the minority group, the Latinx, the African Americans, those that you mentioned, and say this vaccine is safe and effective in you because we have proven by a clinical trial that it is. Whereas if they're not represented in the trial, there's always that lingering feeling that it was tested in a group that's not like them. Therefore, are we sure that it is going to work and be safe in them? We get them into the numbers that you just mentioned, which were quite good. You know, we pushed a lot to get there, and we successfully did get there. So the answer to your question is it's critically important to have the diversity that you mentioned.
So what's the next step? Now that they've announced they've completed the enrollment, what's going to happen next for this trial? And then we'll, in a minute, talk about other trials. But for the moment, what about Moderna? Where are they? What are their goals at the moment?
Well, right now, the goals is to wait until you get events, which are infections. And when you reach a certain number, you can have what's called the first interim look at the data. The way the statistics is set up, when you reach a certain number of individuals, the Data and Safety Monitoring Board, which is an independent board in which the unblinded statistician from that board is the only one who sees the data. Look at the data and determine, is it time now to say we have enough data, or should we continue? Should we stop because the vaccine is in fact not showing any effect at all, maybe even showing a difficulty with it, which would be a safety issue, and then either go on or stop and then present the data so that the company can then present it to the FDA for possible regulatory action. So right now it's wait and see. It's wait and see the number of infections. The first interim look should be, we hope, in the next few weeks.
So everybody wants to know, and you're the guy who's watching this more closely than anybody, what's the likely timetable when there might actually be a vaccine available to the public if all goes well?
Well, Francis, we never know absolutely for sure, but the projections that we have that I think and I hope will be reasonably accurate, that we will know sometime in December whether or not we have a safe and effective vaccine. And practically speaking, when will we be able to deploy that vaccine and get it to those individuals who need it the most, namely the prioritization that came from the ACIP and the National Academy of Medicine? I would think conservatively it would be sometime at the very end of December or the beginning of January.
So we mentioned the Moderna trial, but there are other trials going on right now in the U.S. and other parts of the world. So say a bit more about what other trials are currently underway, at least in our country.
Well, as we know, there are 6 candidates that the U.S. federal government has one way or the other, either in the helping of the development of, as we did with Moderna, or in the facilitation of the clinical trials, as we're doing with the other. There are 6 candidates, 5 of which are now in phase 3 trial. Actually 4, but 1 just about getting ready to go in. So one of the trials that is really essentially neck and neck with regard to temporally with Moderna is the Pfizer trial, because Pfizer and Moderna both went into phase 3 on July 27th. Close behind them is the AstraZeneca and the Johnson or J&J or the Janssen trial. And then we have the trial of Novavax, and then ultimately we have Sanofi, which is a bit behind. Not behind in the sense of quality, but just from a temporal standpoint. So we would likely, Francis, start seeing results from Moderna and Pfizer at approximately the same time.
So I'm looking at questions coming in on the internet, and one is, if you have people who are high risk in your household, should you participate in a trial?
Well, yes, you should participate in the trial, but it's going to be prioritized according to the ACIP's recommendations. The final ones we will be very, very public to people. I can give you a hint of what they are in the sense of that, as in most trials of this type, the people who are the frontline healthcare workers are those who are vulnerable to infections because they're putting themselves at risk. And then you have the people who are involved in the critical infrastructure of the community. Then you have those who have underlying conditions. And then you have elderly without underlying conditions. And then after that, you have everybody else.
I think maybe the questioner was worried that if you were in a vaccine trial, you might actually get the disease and then put somebody at risk. I just want to assure everybody these vaccines are designed in such a way that there is no way they can cause COVID-19. They're producing a small protein that's part of the virus, but it's not the intact virus. So there's no risk there of people around you from being in a trial. Just want to reassure people about that. And if there are people listening who are still interested in signing up to take part in these trials, you can go to preventcovid.org. That's preventcovid.org, and basically register yourself as having interest. That doesn't carry any obligation. But if it looks like a particular trial is going on in your area and they're looking for people, and you happen to be the kind of match that they're looking for as far as other conditions, they might very well get a hold of you. So that's how you can put your name in if you're interested in taking part. How are we going to know, this is the most important question everybody has, that the vaccines really are going to be safe? Are corners being cut here because they hear the word warp speed and it sounds like it's, just pressing forward no matter what? What's the reassurance you can provide here, Tony?
That's a reasonable question, Francis, that I believe you and I get more than any other question. The speed of this is a good thing because of the urgency of the situation. But the fact that we went from a sequence in January, actually January the 9th, to the beginning of the development on the 10th to the 15th, to 63 days later, phase 1, and 6 months later, phase 3, had nothing to do with compromise of safety nor of scientific integrity. It is a reflection, quite frankly, of the years and years of fundamental basic and clinical research that led to the development of the platform technologies that allowed us to make that very rapid switch from a sequence to a vaccine in phase 3. In addition, the time frame is truncated by the fact that investments were made financially in the development of the production of doses so that they would be ready at exactly the same time. A question you asked a moment ago is, when might we feel we can have doses ready? And I said the end of December, the beginning of January. If this were business as usual, there would have to have been a many-month wait while the company gears up to make doses. We have now circumvented that by making a financial risk of making doses before we know it works. So I want to just assure everyone that we will know it's safe because of the fact that we have a 30,000 person trial in one, a 44,000 trial in another, and a 60,000 person trial in another. These individuals will be closely observed both for safety as well as efficacy.
So somebody's asking on the internet, how can I encourage my family members to get the vaccine when it's ready, given all the resistance that is out there that is being documented in various polls where people are just not sure about this? What do we need to do to try to reassure people that they can trust the process to being what it just was said by you to be, very carefully attending to safety and efficacy, because there are a lot of people who are very uneasy about whether they want to take advantage of this or not.
Well, Francis, uneasiness is understandable. I think the best way we can counter that is by being extremely transparent of what the process is. And the process is a sound, tried and true process where you have independent bodies like the Data and Safety Monitoring Board following this very carefully, both for safety and efficacy. When we get to the point, which I hope we will reasonably soon, where there's enough data, enough endpoints that you can make a determination as to safety and efficacy, we then have the career scientists at the FDA who over decades and decades have proven their impartiality and their lack of political influence. We have the commissioner of FDA who has publicly vowed that he would make sure that science would drive the process. There's another committee that is used very, very carefully and intensively by the FDA, the VRBPAC committee, who will also look at the data. In addition, the data will ultimately be transparent to people like you and I, Francis, who, as you know, historically have taken a great interest in making sure that things are done properly. So I would tell the individuals who are skeptical that the process itself is sound, and a lot of people are looking at this very carefully. It will be totally transparent.
Yeah, and I think people should be prepared. When FDA gets to the point where they think it might be justified to issue this kind of emergency use authorization, this group you mentioned called VRBPAC, that's going to be a public meeting. So everybody will get to see what the data looks like. It's not like this is done in some smoky room in the backyard somewhere. This is actually something we can all assess. And so I hope people who are uneasy about this will reserve judgment until they have facts that then they can look at and make up a clear decision about whether this is going to be something they want. I believe that unless we succeed in convincing people that we do have a vaccine that is worth their taking advantage of, we're going to have a very hard time putting COVID-19 behind us, because we have to get enough uptake to be able to achieve that kind of immunity across communities. How about women, pregnant women and children? Are they also being assessed in these vaccine trials?
Francis, that's a great question, because ultimately we want every person who would benefit from a vaccine to get a vaccine. Classically, you do not do that simultaneously with the initial trial. And it works well that way because children obviously are vulnerable. We have safety issues with pregnant women. So before you go into pregnant women or into children, you want to have a reasonable amount of information about the safety and the efficacy of the vaccine. And at that point, we will very likely do things, and it'll be different for different one of the candidates, but a typical prototype approach would be to do a phase 1 trial as you're gathering phase 3 information for the normal adult situation, and do that, and then after a while, after you get enough data from a phase 1, to either do a very quick phase 2, 3, or bridge the data. What do we mean by bridging? Bridging means we look at the response in the populations in question, be they pediatric or pregnant women, And if the induction of a response is similar in those populations to the population in which you've proven by a 30, 44, 60,000 person trial to be effective, then you could bridge that and make a determination that it would be safe and effective for the children as well as for the pregnant women.
Somebody's asking about what's going to happen as far as masking and social distancing. So if we have a vaccine that's been proven safe and effective and we start distributing it, like you're saying, late December, January, does that mean everybody can go back to life as they have enjoyed it in 2019, put away the masks, go to the bars, whatever?
Well, there's a short answer and a longer answer to that. The short answer is absolutely not. The longer answer is that what we likely will have, as the efficacy of the vaccine is shown at the population level, we will have a gradual relaxation of some of the stringent public health measures, never to be abandoned. I can foresee that even with a really good vaccine, that mask wearing will continue well into the third or fourth quarter of 2021. Then what likely will happen when you talk about normality, there will be a graded, gradual progression towards normality. Some examples, I believe restaurants might be able to do indoor at moderate, if not full capacity. Theaters will then be able to seat people, maybe not initially at full capacity, but working your way to that. Sports events will then have spectators, very likely in graded amounts with regard to capacity. So that ultimately, when we get this under control, not only at the domestic, but at the global level, we will start to approach what we call normal. I don't think, Francis, that it's going to be at a level where people are going to feel like there are no public health measures to be implemented until we get to the end of 2021, at least.
So people listening, please be prepared for that. I know Americans are tired of these measures, tired of wearing masks, tired of not being able to congregate together indoors safely, but we've got a long road yet to go. And as you see the cases just going up very steeply right now, we don't have the therapeutics and the vaccines in hand to say this is not a problem. It's a big problem. So we all have to take some responsibility, even more than ever, to try to implement those particular public health measures. And it's one thing to have somebody to tell you to do it. It's another to just decide, I'm going to do this to try to protect my neighbors, my grandparents, all of the other people that I might potentially be infecting without realizing it. Because we know 40% of people who are infected with this virus don't have symptoms, and yet they can be the next super spreader. That might be you. So please wear your mask when you go outside. Keep that 6-foot distance. Avoid those indoor gatherings. Wash your hands. All of those simple things are going to be necessary for months to come. And we should just roll up our collective sleeves of energy here and make sure that happens. So, Tony, people are asking about the vaccine in terms of what the duration of protection is likely to be. Do you want to comment on what we know and what we don't know about that?
Well, the answer is, Francis, we do not know what the duration is going to be. We have to look at a couple of things. We have to take a look at natural infection with the common cold coronaviruses. There are 4 of those. And we do know that there are really clear-cut indications of reinfections that people get after they recover from the identical virus. So we can say that the durability of coronavirus immunity, as it were, the word that we use, protection, is likely not going to be along the magnitude of measles, which, as you know, measles is virtually lifelong. If you get a prime and a boost, the protection is 97, 98% lifelong. Likely not going to be that. We hope it will be at least a year or two so that we can get through a cycle of a season or 2. And then if we need a boost, fine, we'll go with a boost. But right now, we have to say we do not know what the durability of the protection will be of the vaccine.
Is that because the antibodies or the T cells, some people are advocating those are important too, will sort of wane over time, or the virus will mutate over time and the vaccine won't protect you anymore against that new one?
Well, it does not look like this virus is mutating along the lines of what you see with influenza, which necessitates an upgrading of the vaccine virtually every year, but if not every year, close to every year. It certainly is mutating, Francis. It's an RNA virus. It has had a mutation at one amino acid site, 614, which people feel, in fact, might make it more transmissible, but it isn't as a site that would interfere with an antibody that blocks the receptor binding domain. So we don't believe that that's going to have an impact on the vaccine itself. One thing that I think we need to be careful of, just because the level of antibodies diminish, that doesn't mean you lose protection, because you wouldn't want to have a lot of antibody being pumped out indefinitely. You go down and you have what's called memory cells that are there, and that if you get re-exposed, even if the level of antibody is not that high, you still could be protected from a B cell level, as well as getting an amplification of that from the T cell level. Bottom line answer to your question, we're not 100% sure how it lasts, but this is something that's going to be followed very carefully.
Bunch of questions about who qualifies for the trials. Would somebody with diabetes be included as a participant in a vaccine trial?
Oh, absolutely. As a matter of fact, Francis and I have gone over on a weekly basis the participants, particularly in the Moderna trial, and it's broken up into individuals who are 18 to 65 without underlying comorbidities, 18 to 65 with comorbidities, including diabetes, hypertension, obesity, chronic heart disease, chronic obstructive pulmonary disease, and then individuals older than 65. So they are definitely included in the clinical trial.
Yeah, very important, because we know those are people who are at high risk if they get naturally infected with COVID-19. So they're the people we particularly want to make sure the vaccine will work for. Other people wanting to know, if you already have antibodies, presumably because you were previously infected with COVID, do you then not qualify for the trial, or can you sign up anyway? Should you worry about that? Is that like whipping your immune system twice?
Well, don't worry. A. B, you are qualified for the trial. And in fact, those determinations were done on the initial visit. A, is a person actually have virus by a PCR, or do they have antibodies? And it was interesting, depending upon what your demographic group was, whether or not you were a minority, whether or not you were white, whether or not you're a certain age, it varied. But there were people in the trial who tested positive for antibody. They were not excluded from the trial at all.
Slightly different topic, but all related to COVID-19, and something you and I have been talking about, Tony. What is the story with these people who seem to get COVID-19 and then they don't really quickly get better the way you would have thought, the so-called long haulers? What do we know about them, and are they teaching us anything about the safety of the vaccine that we should pay attention to?
Well, I don't think it's going to tell us anything about the safety of the vaccine. I think what it's going to tell us is that the disease itself is really very complicated, Francis. It is not a simple disease. We have people who have moderate symptoms, we have people who have hospitalization, and we have people who require intensive care. What we've seen in a certain percentage, we do not know what that percentage is yet. We're going to find out, because we're doing some significant cohort studies to determine that have a lingering of symptoms anywhere from weeks to months and possibly more, of things like fatigue, shortness of breath, dysautonomia, namely temperature control difficulties, occasional fever, and something which is referred to as sort of a memory loss, or a situation where they can't concentrate, they can't focus.
Yeah, brain fog.
Yeah, they call it brain fog, but we are really concentrating on that. The NIH is sponsoring a workshop on December the 3rd, and Francis and I have been involved in making this a very important part of our leadership forum, to take a look at the kinds of things that we might need to look at in the future. So we are on this. It's a real phenomenon. Regarding the situation that Francis alluded to, could it be telling us something about safety in vaccines? What Francis was referring to is that the spike protein is the major immunogen in the vaccines. And the question is there something about that spike protein that can induce a kind of response, of a hyperimmunological response or other things? I doubt very seriously if that's the case, because we're not giving the body a replicating virus. we're giving the body a simple protein to develop an immune response again. So I don't think the issue of long haulers is going to be impactful when it comes to the safety of the vaccine.
So Tony, we're down to the last couple of minutes. Somebody's asking, why not use monoclonal antibodies for prevention, and then you don't need the vaccine at all?
Well, that's a good question. I mean, if we had monoclonal antibodies, which you could produce for, we'll say 250 million people, then you might want to consider that. No, obviously I'm being semi-facetious, but don't rule out the possibility that passive transfer of monoclonal antibodies is not going to be an important modality of prevention. In fact, we have prevention trials going in prophylaxis for monoclonal antibodies. But from the standpoint of cost effectiveness of a prevention modality, historically, as we know, vaccines overwhelmingly are the best way to go. You give someone a vaccine and they have protection for a long period of time, hopefully. With passive transfer of antibody, it lasts only as far as the pharmacodynamics of the circulation of the antibody. So the best bet is to do it by a vaccine.
Well, we need to wrap up. Tony, I want to thank you for once again bringing your expertise and your wonderful way of articulating these complicated situations so that they make total sense to everybody. Really appreciate it in the midst of everything else that you take time to join these various Facebook and Twitter chats. Everybody, if you are still interested potentially in taking part in one of these vaccine trials, again, the website to go to is preventcovid.org, and there you can register your interest. And of course, I know you'll be tracking all kinds of other things that are happening. The NIH website is always a good place to look for what's new and moving very quickly right now. Again, everybody, please keep safe. Keep in mind that we are not out of the woods. If anything, we seem to be a little deeper in the woods right now with what's happening as cold weather has arrived. So please practice all those public health measures we talked about previously to protect your friends, your neighbors, your families. And we're going to get through this, but we're not there yet. Many thanks, everybody. We're going to sign off now. Thanks, Tony.
Thank you, Francis.